of course, therapy, it works better together with meds than either alone because of, go back to the cognitive neuropsychological model. Yeah, meds can reduce affective biases, meds can help with passive coping with stress and all of that, but you still need to learn the healthier coping mechanisms. That's where therapy can come in. Exercise, whether aerobic or resistance training, can be beneficial, although again, preferably something as a preventive measure than when you're actually depressed. Fun fact, exercise does not actually really result in release of endorphins. That's not true. There is no evidence of that. Rather, mechanisms tied to depression are really more related to increased blood flow, which can lead to increased circulation of neurotrophic growth factors like BDNF, and then certain interleukins through muscle breakdown can actually be beneficial, reducing inflammation, etc. That's mainly it. It's not really related to endorphins at all. You might be surprised that we still do ECT. You might be surprised that ECT or electroconvulsive therapy is still around. Among all of the older treatments, it's the only one that's endured, especially given its evidence base. Now, there are concerns, and rightfully so, based on the history, psychiatry's dark past, even clinical psychology, actually using these methods as means of torture, means of stripping away the human rights of vulnerable populations. This has happened, and psychiatry would be fools to deny its own dark history. But, now with the advent of human rights legislation, international, local, and safeguards in place plus improved technology to make this intervention safer, we have seen that in terms of the risk-benefit ratio, the benefits definitely justify the risk. Or at the very least, if you still feel iffy about it, it's good to have options. Because when you look at what ECT is used for, refractory depression, catatonia in cases of psychosis where the person just isn't moving at all already, is already lying in their own excrement, as one pointed out, and none of the other interventions that have been tried worked at all, it's good to have options, right? In terms of these indications, specifically for refractory depression, for catatonia and psychosis, ECT works. ECT works. How it's done? Well, it might seem scary because basically you're using electrical inputs to stimulate seizures, but of course these are controlled seizures, and apparently it's what underlie the benefits. And as long as it's done, the technique is done properly, and safe guidelines are followed, generally we see good success rates for the indications mentioned. Although compared to, say, other neurostimulation techniques, this one requires you need besides the equipment, of course, it's a bit more invasive. You need an entire team, you need medications, so you have to consider interactions also. You might need to stop certain medications, so there's a bit more complication here. But in terms of the success rate, it's relatively higher, and the benefits tend to endure longer. While, yes, there are side effects, particularly of concern are the cognitive, the memory side effects. We can't deny this, there is a proportion of people who may experience enduring memory loss. Yes, it does happen. But again, like I said, it's good to have options. I mean, consider again the risks of untreated refractory depression, untreated catatonia. If you haven't seen it, I haven't seen it, but I've heard stories. It's really bad. It's really bad. It's good to have options. It's really a discussion of the benefits and the risks with the legal reps, with the family, the carers, and so on. Right? Now, the other neurostimulation modality with some evidence also, repetitive transcranial magnetic stimulation, rTMS. This time you're using a magnetic field. And, well, it's not invasive. You don't need the anesthetics, the muscle relaxants. So less concerns about interactions. Do I need to stop meds? Less concerns about that. No anesthesia as well. However, in terms of the benefits, it is mainly for refractory depression, and the benefits don't last as long. It's not as robust as, say, ECT. And in terms of price, I heard a doctor mention this before. I think we have this at the UST hospital, perhaps other similar centers here in the Philippines. The costs would run you up to 70K, basta 5 digits minimum. So it's a bit on the pricey end also. But, if options. Sleep hygiene, definitely. As baseline, definitely. Many modalities of psychotherapy, but in practice, after having gone through grad school, and having gone through a lot of therapy, I do realize that generally the most preferable approach is to mix and match, because as humans, we're very complex beings. Initially, I was very cognitive, and then I realized I wanted to go back to my past and explore how my past relationships affected my current experiences. That's psychodynamic. And then, I went through this pandemic, brought me through an existential crisis. That's where existentialism can come in. So in practice, it's really more of a mix and match kind of thing. Whichever works better for you. You can even do a bit of self-help. Just a quick bit, a complementary, an alternative meds, because telepharmacies often get a lot of queries about this. So just a very quick bit. Generally, the most evidence for supplements is St. John's wort. And there are still problems, of course, with how supplements are poorly regulated. So they're not very standardized. The problems that come with that. Plus, it's lots of drug interactions with that. Lots of drug interactions. So again, light therapy is mainly for the countries with longer nights during winter, where they're not exposed to a lot of light. So the circadian rhythm is kind of out of whack. And it can lead to what you call seasonal affective disorder. Or depression with a seasonal pattern. That's where light therapy can come in. Dosed and timed exposures to light at certain frequencies. Then the other supplements, they tend to have conflicting evidence. Probably folic acid is something you can recommend for women who are pregnant or expecting to be pregnant, or who have demonstrated folate deficiencies. But otherwise, generally conflicting evidence. The tryptophan thing, by the way, people often say eat bananas during depression, but there have been clinical trials of tryptophan. Generally, no evidence of efficacy in depression. So, I mean, if you like bananas, sure, but yeah. So, that's it. I hope you got a good picture of antidepressant pharmacology in the Philippine context. And yeah. See you in the next videos. Or if this is your last video, thanks for watching. Like, subscribe, hit the notification bell, blah, blah, blah.